Good morning, everyone. Myself, Dr. Deepika Dash, working as adult intensivist in UNMICRC Institute of Cardiology and Research Center. Today, we are discussing one of the most pressing challenges in modern critical care: multi-drug resistant infections in Indian ICUs. This 2024 update integrates the latest clinical guidelines and epidemiological data from the Indian Journal of Critical Care Medicine, the ICMR, the WHO, and the IDSA. Our goal today is to bridge the gap between surveillance data and bedside clinical practice. So, we often talk about high profile outbreaks, but AMR is the silent pandemic occurring within our ICU walls right now. In India, antibiotic resistance has reached a critical threshold. This isn't just a microbiological concern, it is a direct threat to patient survival. The 2024 guidelines we are discussing are no longer just suggestions. They are our essential protocols required to navigate an era where our last line drugs are failing. Let's look at the hard data from the 2024 ICMR AMR Research and Surveillance Network. The numbers are frankly alarming. Carbapenems, once our go-to for serious sepsis, are losing ground. E. coli resistance to imipenem is now at 42.4%. Pseudomonas is nearly identical at 43%. Klebsiella pneumonia shows a staggering 68.8% resistance, and most critically, Acinetobacter baumannii is at 88% resistance. This tells us that in many Indian ICUs, carbapenems can no longer be used as reliable empirical therapy. So, when we look at the ventilator associated pneumonia, the 2024 ICMR data shows a clear pattern. Nearly 80% of the VAP cases are caused by just 3 gram negative bacilli: Acinetobacter baumannii, Klebsiella pneumonia, and Pseudomonas aeruginosa. While we must keep an eye on staph and fungal infections, the battle for survival in the Indian ICUs is primarily fought against these 3 highly resistant pathogens. The ESCAPE acronym identifies our most troublesome organisms. It represents a group of organisms that have effectively escaped the biocidal effects of our standard antibiotics. In the Indian ICU context of 2024, these are primary drivers of healthcare associated infections. So let's break down the current status of each. First, E stands for Enterococcus. We are seeing a significant rise in vancomycin resistant enterococci. Specifically, Enterococcus faecium has become the dominant species in serious bloodstream infections. It is notoriously more resistant than Faecalis, often requiring us to move straight to linezolid or daptomycin. Then S stands for Staph aureus. While gram negatives get most of the attention, MRSA remains a formidable threat with a prevalence rate of 53% in 2024. The good news is that vancomycin remains largely effective, though we must watch for MIC creep cases where the bacteria are still sensitive but require much higher doses to kill. Then K stands for Klebsiella. This is perhaps our most resource heavy pathogen. It is a major producer of carbapenemases, specifically the OXA48 and NDM enzymes. These enzymes allow it to chew through almost all beta-lactam antibiotics, including our most potent carbapenems. Then A stands for Acinetobacter. This is the problem child of the Indian ICU. With an 88% carbapenem resistant rate, most of our isolates are now classified as XDR, extremely drug resistant. In many units, we are down to using only polymyxins or high-dose sulbactam combinations. Then P stands for Pseudomonas. We are seeing a steady increase in difficult-to-treat isolates. These strains require optimized high-dose extended infusions to overcome their various resistant mechanisms such as efflux pumps and porin mutations. Then E stands for Enterobacter. Finally, Enterobacter species often carry AMC beta-lactamases. These are inducible enzymes, meaning the bacteria might look sensitive to cephalosporins in the lab, but will rapidly develop resistance once the patient starts the treatment. So, choosing the right antibiotic requires understanding the molecular soup of the resistance. This is perhaps the most important reason why our standard protocols often fail in the Indian ICU. In India, we aren't just dealing with one type of resistance, we are dealing with a genetic mosaic where multiple resistance patterns, genes coexist in a single pathogen. So let's look at the most common culprits found in our units. First is Klebsiella pneumonia. The TM gene is the most prevalent, providing broad resistance to many early generation penicillins. However, the real clinical challenge is the OXA48 and NDM1. NDM, which is the New Delhi metallo-beta-lactamase, is a class B enzyme that makes the bacteria resistant to almost all beta-lactams, including carbapenems, except aztreonam. The problem, these bacteria often carry SHV gene as well, which do destroy aztreonam. So this is exactly why we often have to combine drugs to protect one another. Next is E. coli. We see a similar diversity here with the TM gene leading the way. We also see significant presence of IMP and VIM genes. These are carbapenemases that are highly mobile, meaning they can jump between different bacteria in the same patient, rapidly spreading resistance across the unit. So the clinical challenge is that the sheer diversity of these enzymes in India, specifically the coexistence of NDM and OXA48, is what makes choosing a BL-BLI combination so difficult. A drug like ceftazidime avibactam works perfectly for OXA48, but it is powerless against NDM. So we have to combine aztreonam to be effective. So how do we identify these patients who are most likely to be harboring these resistant pathogens? The ICUs-CCE 2024 guidelines have categorized these into a specific set of risk factors, and evaluating for them is now a class 2 recommendation for anyone presenting with community acquired or ventilator associated pneumonia. So when you are at the bedside, you need to check for these 5 critical markers. First is hospitalization. Has the patient been admitted to a healthcare facility for more than 48 hours within the last 3 months? Short stays are often overlooked, but they are prime opportunities for colonization with hospital acquired MDR flora. Second is prior antibiotic exposure. This is perhaps the strongest predictor. If a patient has received any antibiotic therapy in the preceding 90 days, even for a minor infection, it has already applied selective pressure to their microbiome, potentially leaving behind only the most resistant strains. Third is demographics and comorbidities. We must be more vigilant with patients over 65 years of age. When you combine age with comorbidities like diabetes, chronic lung disease, heart failure, the patient's immune system is less capable of fighting off low virulence but high resistance MDR organisms. Fourth is healthcare exposure. This covers our frequent flyers in the healthcare system. Patients on chronic dialysis, those receiving home wound care, or those on long-term infusion therapy. These patients exist in a constant loop between the community and the healthcare settings, acting as a bridge for MDR transmission. Fifth and the last one is the colonization history. Does the patient or a close family member have a known history of MDR colonization? In our 2024 landscape, we must recognize that MDR is often a household or a community-wide issue, not just an individual one. So, one of the most significant shifts in 2024 guidelines is to move from reactive to proactive microbiology. In the past, we were forced to wait for 48 to 72 hours for traditional culture results. In a modern ICU, that delay is often the difference between life and death. We are now utilizing three core diagnostic technologies to get ahead of the infection. First is multiplex PCR. This is our first line of defense. Unlike traditional cultures that grow the bacteria, PCR look for the DNA of the pathogen and its resistant genes. It can identify the organism, or more importantly, whether it carries genes like NDM or OXA48 within just a few hours. According to ICUs-CCE 2024 guidelines, implementing multiplex PCR can reduce inappropriate antibiotic usage up to 30%, allowing us to narrow our therapy much sooner than previously possible. Second is next generation sequencing and plasma cell free DNA. For our most complex cases, specifically culture negative sepsis, where the patient is clearly deteriorating but the blood bottles remain empty, we now look to the next generation sequencing and plasma cell free DNA. These technologies can detect fragments of DNA from over 1,000 different pathogens, bacteria, fungi, and viruses simultaneously. It is particularly useful for identifying hidden or slow growing organisms that traditionally methods simply miss. Third is antigen assays. Finally, we should not overlook the quick wins. Urinary antigen assays for Legionella and pneumococcus are recommended early in the ICU stay. These are simple, rapid tests that allow for immediate targeted therapy for pneumonia, preventing the overuse of broad spectrum carbapenems while we wait for more complex results. In the ICU, we are often forced to act before the lab results are in. The 2024 guidelines emphasize that empirical therapy is not guesswork. It is a high stakes clinical calculation based on two non negotiable principles. The first, golden hour. The most critical takeaway from this is the 1 hour rule. So, the goal for the patients in septic shock or severe sepsis is appropriate antibiotic therapy must be initiated within 60 minutes of recognizing the condition and obtaining the cultures. Data shows a linear relationship between the delay in effective antibiotic administration and an increase in the mortality. Every hour of delay is associated with a significant drop in the probability of survival. Second is individualization of therapy. We have moved past the era of one size fits all protocol. The 2024 update stresses that your empirical choice must be tailored to the specific patient sitting in front of you. This is based on two factors, the local antibiogram and patient risk profile. You must know the microbial weather of your specific unit. If your unit has a 40% rate of carbapenem resistance, your empirical therapy for a crashing patient cannot be meropenem alone. For the patient risk profile, as we discussed before, we must screen for MDR risk factors. If the patient has had prior exposure to beta lactams, your empirical coverage must jump to the next tier, covering for the ESBL, Enterobacterial, Pseudomonas, or MRSA immediately. So, the right drug is useless if it is used at the wrong dose. In the ICU, the standard dosing on the package insert often fails because patients have altered volumes of distribution or augmented renal clearance. We need to focus on pharmacokinetics and pharmacodynamics to ensure we achieve therapeutic success. The four pillars, which includes time is more than MIC. For beta lactams like penicillins, cephalosporins, and carbapenems, the efficacy depends on the duration that the drug concentration remains above the minimum inhibitory concentration of the bacteria. We generally aim for the drug level to be above the MIC for at least 40 to 50% of the dosing interval to ensure optimal bactericidal effect. Second is continuous infusion. This is a major 2024 recommendation that instead of a traditional 30-minute bolus, giving beta lactams via extended 3 to 4 hours or continuous infusion helps maintain steady drug levels. This strategy is preferred because it has been shown to decrease hospital stays, lower costs, and reduce mortality in the most critically ill patients. Third is glycopeptides or like vancomycin. While the data shows a clear mortality benefit for continuous versus intermittent vancomycin, continuous infusion is a highly recommended for safety. It significantly reduces the risk of nephrotoxicity and makes it easier to achieve target therapeutic levels. Last is therapeutic drug monitoring. We can no longer dose blindly. Therapeutic drug monitoring is now considered essential, especially for aminoglycosides and vancomycin in patients with renal failure. By measuring actual blood levels, we ensure the dose is high enough to kill the bacteria but low enough to avoid organ toxicity. Moving from the theory of PKPD into actual practice, this slide details the specific infusion strategies for beta lactams. As we discussed on the previous slide, these drugs are time dependent, meaning their success depends on how long the bacteria are exposed to a concentration above the MIC. In the 2024 Indian ICU context, we are moving away from traditional 30-minute bolus dosing for several critical reasons. Extended infusions of 3 to 4 hours, this is now the recommended standard for drugs like meropenem, piperacillin, tazobactam, and ceftazidime. By stretching the infusion over 3 to 4 hours, we significantly increase the time the serum concentration stays above the MIC. This is especially vital when dealing with borderline resistant organisms where the MIC is higher than usual. For our most critical ill patients, those in septic shock or with highly resistant gram-negative infections, a 24-hour continuous infusion is the gold standard. This provides a flat, steady-state concentration, ensuring there are no dips in drug levels where the bacteria could potentially recover or develop further resistance. In loading doses, a common mistake in the ICU is starting a slow infusion without a kickstart. So, this emphasizes that every extended or continuous infusion protocol must begin with a rapid loading dose. This ensures we reach therapeutic levels within minutes rather than hours, which is vital during the first golden hour of sepsis. For the stability considerations, clinically we must remember that not all drug must stay stable at room temperature for 24 hours. For example, while meropenem is highly effective, it has limited stability once reconstituted. Therefore, for continuous infusions, the syringes may need to be changed every 6 to 8 hours to ensure the drug remains active. By adopting these infusion strategies, we aren't just giving more medicine, we are giving medicine in a smarter way. We improve clinical cure rates, and according to recent ICUs-CCE data, we actually reduce the overall duration of antibiotic therapy required. CRE is where the battle gets difficult. According to the 2024 data, nearly 43% of Klebsiella and E. coli isolates are now resistant to the carbapenems. This outlines how we must tailor our therapy based on the specific resistance flavor or enzyme the bacteria is producing. The 2024 guidelines emphasize a targeted approach rather than a one-size-fits-all combination. The NDM with OXA48 challenge, unlike in the West where KPC enzymes dominate, India is the epicenter for NDM, New Delhi metallo-beta-lactamase, and OXA48. This is a critical distinction because many newer antibiotics work for one but not the other. So, ceftazidime avibactam is our primary weapon against OXA48 and KPC producing organisms. It has shown a significant clinical cure rate advantage over older toxic therapies like colistin. However, this cannot kill NDM producing bacteria on its own. So, the double coverage strategy for patients suspected of having NDM, which is very common in our ICUs, the 2024 update recommends combining ceftazidime-avibactam with aztreonam. Is Aztreonam is naturally resistant to the NDM enzyme but is usually destroyed by the other enzymes the bacteria carries. By adding ceftazidime-avibactam with aztreonam, we protect the aztreonam, allowing it to reach and kill the bacteria. This synergy is currently the gold standard for NDM heavy regions. Cefiderocol. So, this highlights the role of cefiderocol, often called the siderophore or the Trojan horse antibiotic. It mimics iron to trick the bacteria into pulling the drug inside its cell wall. It is one of the few single agents effective against both NDM and OXA48, making it a vital last resort option for extremely drug resistant infections. Next is difficult to treat Pseudomonas aeruginosa. This term DTR specifically used for Pseudomonas that is resistant to all first line agents including piperacillin tazobactam, ceftazidime, cefepime, aztreonam, meropenem and imipenem. So when we are back into this corner, the 2024 guidelines suggest a very specific hierarchy of treatment. For DTR Pseudomonas, the preferred choice is often ceftolozane tazobactam. This agent was specifically engineered to overcome the common resistant mechanisms of Pseudomonas such as efflux pump overexpression and porine loss. Ceftazidime-avibactam is another stronger contender, though its use is often prioritized for Klebsiella. The role of cefiderocol. Cefiderocol is a Trojan horse that is exceptionally effective against DTR Pseudomonas because it bypasses the traditional entry barriers that the bacteria uses to keep other antibiotics out. High dose combination therapy. If these newer agents are unavailable, we must resort to older, more toxic combinations. This usually involves high dose colistin or polymyxin B paired with an aminoglycoside like amikacin or a phosphomycin infusion. So, the power of infusion is regardless of the drug chosen, Pseudomonas therapy lives or dies by its PK/PD optimization. For Pseudomonas, we must use extended infusions at least 3 to 4 hours to maximize the time above MIC. This is because Pseudomonas often has intermediate sensitivity and a standard bolus dose simply won't maintain the high concentrations needed to clear the infection from deep tissues like the lungs. Next is carbapenem resistant Acinetobacter baumannii. As our epidemiology data showed earlier, with an 88% resistance rate, we are often dealing with extremely drug resistant strains that leave us with very few choices. The 2024 management strategy for Acinetobacter rely on high dose combinations as monotherapy almost always leads to resistance and failure. So, high dose ampicillin sulbactam remains a cornerstone of therapy. For CRAB, we use extreme doses of sulbactam component, often up to 6 to 9 grams per day, delivered via extended infusions. Sulbactam has a unique affinity for the penicillin binding proteins of Acinetobacter, making it a primary weapon even when the bacteria is resistant to other beta lactams. Minocycline or tigecycline, these tetracycline derivatives are frequently part of the backbone. While tigecycline is useful, we must be cautious with its use in bloodstream infections because it achieves very low serum levels. In those cases, high dose minocycline is often preferred if available. Next is polymyxin B or colistin. For many XDR strains, a polymyxin remains the last line. The 2024 update stresses that polymyxin should never be used alone for Acinetobacter. They should always be paired with a second agent, such as sulbactam or a carbapenem, using the overriding principle to maximize killing power. Cefiderocol is the newest addition to our arsenal. It has shown significant promise against Acinetobacter by utilizing its Trojan horse mechanism to bypass the bacteria's thick outer membrane. So while gram negatives dominate, MRSA still accounts for over 50% of Staphylococcus aureus infections. Vancomycin remains the standard, but we are seeing an MIC creep. So if the vancomycin MIC is more than or equal to 2 microgram per ml, we should pivot to linezolid or daptomycin. For MRSA pneumonia, linezolid is often preferred due to better lung tissue penetration compared to vancomycin. While we often focus on gram-negative bacteria, enterococci are resilient gram-positive organisms that are increasingly implicated in bloodstream infections and surgical site infection. Vancomycin resistance in enterococci has reached 17.5% in 2024. And more importantly, the species Enterococcus faecium has become the dominant player in ICU-acquired bloodstream infections. Unlike Fecalis, faecium is notorious for showing much higher levels of resistance to traditional antibiotics, leaving us with a very narrow therapeutic window. So, linezolid as first line for VRE bloodstream infections, this remains our primary go-to drug. It offers excellent tissue penetration. However, in the ICU, we must monitor for linezolid-induced thrombocytopenia, especially when the treatment extends beyond 10 to 14 days. Next is high-dose daptomycin for serious deep-seated infections or endocarditis where a bactericidal effect is needed. Daptomycin is preferred. The 2024 guidelines suggest using high doses rather than standard dosing to prevent the emergence of resistance during treatment. Tigecycline for specific sites. In cases of complicated intra-abdominal infections or soft tissue infections involving VRE, tigecycline is a valuable component of or combination regimen. We must remember tigecycline is generally avoided in primary bloodstream infections due to its rapid distribution out of blood into the tissues. So, we transition from bacterial threats to a fungal pathogen that has become a major crisis in Indian ICUs, Candida auris. This is not your typical yeast infections. Candida auris is often referred to as a superbug because it behaves more like a multi-drug resistant bacterium than a fungus. There are three reasons why this pathogen is specifically highlighted in the 2024 update. Environmental persistence. Unlike most other Candida species, it has an incredible ability to persist on surface bed rails, monitors, and even skin for weeks. It is highly resistant to standard disinfectants, which often leads to devastating or outbreaks within our ICU. Second is high resistant profile. Candida auris is notorious for its high resistance to fluconazole, which is our traditional first-line antifungal. In fact, many strains show require a reduced susceptibility to all three main classes of antifungals, making it an extensively drug-resistant fungal threat. Last is treatment strategy. As per the 2024 ICU-CCE recommendations, echinocandins such as micafungin, anudolafungin or caspofungin are the empirical drug of choice for suspected Candida auris infections. So we do not wait for sensitivity results to start an echinocandin if we suspect a fungal source in a critically ill patient. And management needs strict contact precautions as well. So we address the systemic solution to the resistant crisis, antimicrobial stewardship. In an environment where 88% of Acinetobacter is a carbapenem resistant, we cannot simply rely on our newer drugs. We must preserve the ones we have. The 2024 guidelines outline 3 specific interventions that every Indian ICU should implement to improve patient outcomes and curb resistance. First is prospective audit and feedback. This is the most dynamic part of the program. It involves a daily or a real time review of the antibiotic orders by the infectious disease specialist or a clinical pharmacist. Instead of just looking at the chart once, the team assesses the patient, clinical progress, culture results, and the inflammatory markers every 24 to 48 hours. They then provide direct feedback to the bedside intensivist to either narrow the spectrum, adjust the dose, or stop the drug entirely. Next is pre authorization. This is our gatekeeping mechanism. For high tier, last resort antibiotics such as ceftazidime, avibactam, cefiderocol, or polymyxins, the 2024 protocol suggests they should not be open shelf items. Clinicians must obtain approval from a designated stewardship lead before the first dose is dispensed. This ensures these silver bullets are reserved only for cases where documented resistance or high clinical risk truly justifies their use. Last is duration control, the 7-day rule. One of the biggest drivers of resistance is keeping the patients on antibiotics for far too long. The 2024 update highlights a shift from traditional 14-day courses to a 7-day courses for more stable ventilator associated pneumonia and hospital acquired pneumonia patients also. Data shows that for most pathogens, 7 days of therapy is just as effective as 14, but with a significantly fewer side effects and a much lower risk of the patient developing a secondary MDR infection like Candida auris. In an era of MDR, the decision to stop an antibiotic is just as important as decision to start one. The 2024 ICUs-CCE recommendations provide very clear instructions on how to use this biomarker effectively without falling into common diagnostic traps. First and foremost, the guidelines give a class 1A recommendation against using PCT to differentiate between bacterial and viral etiologies in community acquired pneumonias. PCT is not a litmus test for infection. It can be evaluated in non infectious conditions like trauma, major surgery, or severe burns. We should never use a single PCT value as sole reason to initiate or withhold antibiotics. Where PCT truly shines in de-escalation, the 2024 standard is to measure PCT at baseline and then serially every 24 to 48 hours. This allows us to track the kinetic of the infection. A downward trend is a powerful indicator that the host inflammatory response is subsiding and the current antibiotic regimen is working. So, when the PCT is less than 0.25 nanogram per ml, this strongly suggests that the bacterial load is minimal and we should stop the antibiotics. So by following this PCT guided protocol, studies show we can reduce the duration of antibiotic exposure by 2 to 3 days without increasing the mortality or relapse rates. In a unit full of MDR pathogens, those 72 hours of antibiotic free time are crucial for preventing the further selection of resistant strains and reducing the risk of Clostridium difficile or Candida superinfections. Though the most effective way to manage MDR infections is the infection prevention. We are looking at the WHO core components, which are our primary barriers against the spread of XDR organisms within the unit. So we break this down into 3 fundamental pillars. First is hand hygiene. This remains the single most effective way to break the chain of transmission. In the ICU, we emphasize the WHO 5 movements. It is not just about washing hands before touching a patient, but critically after touching the patient's immediate environment, bed rails, monitors, or infusion pumps where pathogens like Acinetobacter can survive for weeks. Next is environmental cleaning. Standard cleaning is no longer enough for modern ICU threats. For high-risk pathogens like Candida auris or XDR Acinetobacter, the 2024 guidelines recommended enhanced protocols. This includes terminal cleaning using automated UVC light or hydrogen peroxide vapor to decontaminate surfaces that manual piping might miss. Last is active surveillance. We can't fight what we don't see. Active surveillance involves screening at risk patients for carbapenemase resistance producing enterobacterials upon admission. By identifying asymptomatic carriers early, we can implement contact precautions immediately, preventing a single carrier from sparking an outbreak across the entire ward. So, we can discuss the newest antibiotics for hours. But the hard truth of infectious disease is that you cannot medicate your way out of the undrained collection. So, antibiotics are merely a bridge to buy time, but source control is the cure. In the 2024 update, the IJCCM and the IDSA place heavy emphasis on the search and destroy mission. This means rapid identification, physical intervention, and zero WAP bundle should be done. So for the rapid identification, within first 6 to 12 hours, we must identify the anatomical source. If the patient has a central line and new onset sepsis, that line is guilty until proven innocent. Physical intervention includes the removal of infected hardware, IV catheters, urinary catheters, or pacemakers, the drainage of abscesses via intervention radiology, or surgical debridement of necrotic tissue in cases like necrotizing fasciitis. The zero WAP bundle, since our data shows 80% of ICU pathogens are gram-negative infections like Acinetobacter, we must prevent the source from forming in the lungs. This involves the 30 to 45 degree head end elevation, daily sedation holidays to assess weaning, and subglottic suctioning. So, the best antibiotic stewardship is to prevent the infection in the first place. While we have spent much of today discussing how to manage with limited resources, the newer antibiotic pipeline is finally bringing much needed reinforcements to the Indian market. Cefiderocol is perhaps the most anticipated drug in the pipeline, known as the Trojan horse antibiotic. It binds to the extracellular iron and is actively transported into the bacterial cell. It is unlikely, it is uniquely stable and against nearly all carbapenemases, including NDM, OXA48, and KPC, making it a potentially game changer for Acinetobacter and Pseudomonas. Newer BL-BLI combinations. So we are seeing the introduction of agents like meropenem vaborbactam and imipenem cilastin relebactam. These are designed specifically to inhibit the KPC type of resistance. While KPC is less common in India than NDM, having these tools allows us to save ceftazidime avibactam for the cases where it is most needed. Next is sulbactam durlobactam. This is a highly specific weapon designed almost exclusively to target Acinetobacter baumannii. By pairing a potent new beta-lactamase inhibitor with sulbactam, it restores the activity of the drug against even the most resistant crab strains. So, the responsibility of access. The 2024 update makes it clear that as these drugs enter our ICUs, we must not repeat the mistakes of the past. These are orphan drugs, they must be guided by strict pre authorization and reserved only for patients with documented resistance to all other options. So, we are moving away from protocol based medicine towards precision medicine, where the treatment is as unique as the patient's own generic and microbial footprint. So, these are three pillars that will define the next decade of our practice. Personalized antibiograms. Currently, we rely on unit antibiograms, a mathematical average of everyone's resistance. The future is whole genome sequencing. By sequencing the specific pathogen from a patient in real time, we can identify every single resistant gene they carry. This allows us to tailor therapy to that specific individual's resistance profile, ensuring 100% accuracy in drug selection from day one. Next is AI in antimicrobial stewardship. Artificial intelligence and machine learning are becoming our digital partners. AI can analyze thousands of data points from white cell counts and temperature trends to local resistant patterns to predict which patients are likely to fail standard therapy. It can also optimize dosing by calculating real time PK/PD adjustments for patients on CRRT or those with fluctuating organ function far more accurately than manual calculations. Last is bacteriophages. Perhaps the most exciting back to the future technology is the use of bacteriophage viruses that naturally kill specific bacteria. For pan resistant infection, where no known antibiotic works, phage therapy offers a non antibiotic alternative. So offers we are already seeing successful case reports in India where phage works. We used to treat XDR, Acinetobacter and Klebsiella when all our silver bullets had failed. Thank you.